What are the common toxins we come across in and out in our ICUs or in emergency rooms? The common toxins which I encountered in the last 30 years or 20 years of this medical career is the pesticides. Organophosphorus, organochlorides are the most common pesticides which we come across. There is a slight shift of these pesticides nowadays to herbicides and paraquats. So I don't know how many of you are encountering this. There is a shift that we are seeing more and more herbicides and paraquats recently. Supervasmol, the hair dye, which one of the commonest intoxicated patients who used to come a few years back. I have seen a decline in recent times, but in 2010s to 2015s, I have seen a lot of supervasmol poisonings. Rodenticides, we're talking about anticoagulants, let's say coumarin, warfarin derivatives, and also yellow phosphorus. Aluminum phosphide, these are one of the commonest poisons which we come across. They landing into acute liver failure, and we had few cases of that. The toilet cleaners, corrosive acids, corrosive alkalis has been also a common poisonings. The drugs like some of the family members are taking antipsychotics, benzodiazepines, beta blockers, calcium channel blockers, anti-diabetic medicines, overdose of thyroxines has been also not uncommon. Many of the times we see a cocktail of 5-6 medicines consumed by the family member where they got these medicines from their other family who are using them. Acetaminophen toxicity, not even though uncommon, not common as we see in the West. And I am surprised to see many acetaminophen patients who come with even 15 grams of paracetamol intoxication, hardly many of them go into the acute liver failure. I don't know whether we have a robust management system of acute acetaminophen, or we should thank our industry colleagues who manufacture such a high quality of acetaminophen, either of that. Some of the times petroleum products has been also a problem in those situations. I am listing this because we may have a very different toxidrome which we learn in textbooks, but these are the common poisons which we come across day in and out in Indian context in Hyderabad intensive care units. What is our problem? I'll just try to narrate a story. A young girl in my previous organization was shifted from a remote part of Andhra Pradesh, saying that this girl is not well with multi-organ failures and slowly deteriorating, came to our ICU. And has been known to some police commissionerate, so they have called us and admitted under the Department of Critical Care Medicine. Initially, when we evaluated, we found to have the patient is having acute liver failure, the patient is having some form of renal shutdowns, the patient is having difficulty in swallowing, difficulty in breathing, and whatnot. There is some leukocytosis, there is dyselectrolemia, there is acidosis and all that sort, and lactitemic. And this, they give a history of 6 to 7 days of time. So, Vishnu. They give a history of 6 to 7 days of time of all these problems. The girl was otherwise normal. And this girl was evaluated extensively in that local place, talking about this is all possibly because of some autoimmune, some other tropical fevers, hepatorenal phenomenon, pulmorenal phenomenon and all. This girl finally landed in our ICU, and when we tried to evaluate and see there is a multiple organ failure, we tried to see all the tropical workup which was negative, ANA profile which was evaluated outside was negative, there is no correlation of many of the things. This girl was otherwise healthy. On our first day rounds, we realized that this patient had a very difficulty in swallowing, and he says there is a lot of pulling of saliva. When we examined her oral cavity, the whole oral cavity has a significant amount of corrosiveness with hyperemia, the whole throat and all. And when we attempted to do an endoscopy, the whole esophagus is burnt out. And when we inquired with that girl, did you had any consumption of any corrosive pesticides or anything, the girl has a complete denial. She says, I have not done anything else. When we inquired with the family, they and that police family, that's a very influential family, they said, no, nothing such can happen. Why are you talking about all this? We came with so many problems and this has been evaluated and there were so many differentials. Why are you now pushing into some kind of medical legal issues? Then after a lot of pursuance, we said, please help us out, go back to the home and just inquire and see what is happening there, in and around that. And finally, at the end of the second day, after a lot of pursuance, they got a bottle of, a yellow color bottle of pesticide in the bathroom on one of the corners, which is found empty, and that found to have paraquat. So just imagine, for a week of the time, this girl was being treated as evaluating the possibility, because all of you are aware, paraquat initially may not manifest with any organ failures. It may just have a corrosiveness and the injuries which has oral cavity and esophagus. Later in day 3 and day 4, you slowly start having renal shutdowns. Then maybe in a week time, you see having a liver dysfunction, and over a time, you may see a hypoxemia and lung dysfunctions in them. So during this whole period, this girl used to have a hepatorenal, then pulmonorenal, and all of us were breaking our head on those angles, differentiating them. What are the possible reasons for hepatorenal? What are the possible reasons for pulmonorenal and all? And at least at the end of a week or 10 days, this girl, when the family accepted, they even initially has a lot of hesitancy for even making it an MLC case, even the family being a police professionals. What I'm trying to say is, the social stigma in India is still a very big burden for us. Many of the time they don't express in view of the reputation, in view of a young girl being consuming some or the other poisoning. So they try to avoid all that information. And sometimes it is deliberate, sometimes the girl probably with an apprehension has not expressed also. So there will be a wide range of symptoms, there is a wide range of clinical findings, and sometimes there will be associated problems, like a person who actually gets a trauma because he had a fall after some sedative intoxication. So that will also cause some amount of overlap. And underlying diseases, psychiatric illness, underlying renal issues, underlying kidney issues, these also will have a complexity. Sometimes co-ingestion, cocktail of 2 or 3 drugs, these also will make some form of confusion and overlap. So what do we know and how do we suspect them? Whenever I found a host who is absolutely normal and I do not have any clue why this patient will have so many abnormalities suddenly, then I will always keep an eye that whether it can be an intoxication. That is one. Any patient who has underlying psychiatric illness comes suddenly to you with a lot of instability fitting into one of your syndrome, I'll keep on looking at that. And when you actually examine these oral cavities, most of these corrosive, including paraquat, you will have a definite findings in all your aerodigestive tract, which will give you a clue that there is something going wrong there. So that's the story. So we initially have to focus on them. So initial evaluation should be a very focused examination. We'll not go into those details. The basic things which we do after airway stabilization, vitals, mental status, pupil, skin temperature, moisture, moistness of the skin, a quick capillary glucose, ECG monitoring in a patient who is an altered sensorium, and a quick IV access. IV glucose. We have been all taught to us that any patient comes in an altered sensorium, we will quickly look at the GRBS in them and supplement glucose if you don't have a glucometer at home or you don't have a glucometer facility. There's a lot of hypothetical things which has been taught to us from the medical school days, that if a patient who is ethanolic or if a patient where you suspect thiamine deficiency, never ever use IV dextrose before thiamine. I think all of we believe that the thiamine, if not supplemented before glucose and you give a glucose, it can cause a vernix and that will precipitate further. So there is a change in this concept. If you look at the up-to-date currently, they say no. It's not true anymore. If somebody is a severely hypoglycemic, dying out of hypoglycemia or losing neurons out of hypoglycemia, you taking time for thiamine, don't worry, supplement glucose. You can later on supplement thiamine in the same time. But if you have both, supplement together. The take home here is that thiamine, if it is not available, you have dextrose, somebody is hypoglycemic, give glucose and treat the hypoglycemia first. Maybe you can add on thiamine later. So diagnosis of poisonings, as this all the clinical pulse has been about a case discussions, are taking into a syndromes. So we will try to take you into syndromes. These are the 5 most common major toxidromes which we talk about: anticholinergic, cholinergic, sympathomimetic, opioids, and sedatives. So we will just go through these 5 cases and we'll go to the next lecture. So this is an 18 years old boy or old lady came to the emergency room who had found unresponsive for the last 8 hours and not waking up, and his vitals in the emergency room is around 105 heart rate with a respiratory rate of 10, a borderline hypertension and hypothermia. How should we proceed? What is this toxidrome looks like? Bradypnea, borderline pressures, hypothermia. We are trying to actually focus on 5 toxidromes: sympathomimetics, anticholinergics, cholinergics, opioids, sedatives. So CNS depression, somebody who suddenly found a otherwise healthy 18 years old boy in CNS depression, slurred speech, ataxia, coma, stuporous, respiratory depression, apneas, hypertension, hypothermia. They go into a toxidrome called sedative hypnotic toxidrome. So the most common drugs which we come across anytime, whenever we come across these kind of syndromes, are benzodiazepam, barbiturates, and we see this one of the common, alprazolam 50 tablets. Some of the lorazepam 20 tablets, clonazepam 20 tablets. These are one of the common things. So how do they behave? They will just be in a comatose state. They will not respond. They will be bradypneic. The heart rate will be somewhere around 90, 80. Sometimes the borderline pressures because of the the sedative effects of that. And most commonly we find them to be benzodiazepam. Unfortunately, many of them, what happens is we send them this toxic panel or this poisoning panel in the urine and all. And many of these patients, when we intubate them, when they are bradypneic or they are hypotensive or they are apneic, most of them will be receiving some form of midazolam or some form of opioid. So urine toxicology will always reflect some form of midazolam in them or a benzodiazepam dose positive. So this is one of the confounding factor. But what we do is we ask them to send a benzodiazepam levels in them, midazolam levels. That will give you a clue. And what about the treatment? So what about the generally treatment? We talk about flumazenil, which is a reversal agent, and most of the times we don't use this flumazenil reversal agent in this benzodiazepam overdose suspected patient at least. The reason is whenever there is a cocktail of intoxication with benzodiazepam and a TCA poisoning, generally when you reverse this benzodiazepam effect by a flumazenil, these patients may lower the threshold of seizures and they start convulsing. So the benzodiazepams are protective for them. Till I am very convinced that this patient is only taken benzodiazepam, I will not try to use a flumazenil reversal. So this is again a clinical part. The second part is flumazenil will be a very short acting. I give a full dose of flumazenil, reverse back the benzodiazepam overdose activity. The patient will be more conscious, more active, and you just leave that place, and within no time there will be a call saying the patient went into apnea and arrested. So either you need to be there to see and you need an infusion, or you don't use them and just wait. If you have a benzodiazepam overdone, ventilate and wait for the drugs to have to go away. The reason why we do this all is flumazenil should be used only to, if you have a suspicion, you wanted to diagnose, you give it, see the reversal, and then continue your management. Don't try to use flumazenil to treat. Some of the clinicians have a second school of thought. They use a flumazenil infusion over days to prevent the intubation in them. But you have to be very, very careful, be bedside, monitor them. So we will go to the next syndrome. A 34 years male found at home by wife as a combated, agitated and confused state, tachycardic, borderline hypertensive, temperature looks normal, tachypneic, bilateral pupils are 5 millimeters and dilated. There is a dry skin, flushed, distended bladder, which is palpable till the umbilicus. So we have a typical syndrome of anticholinergic with mydriasis and altered sensorium, tachycardia, dry mucous membrane, flushed skins, urinary retention, constipation, and there is an absence of diaphoresis. This is again, I'm repeating, skin will be dry. So we all talk about dry like this, hot like this, flushed like this. So we have been seeing those mnemonics in our school days. So these are the common anticholinergics which actually generally cause atropine, scopolamine, antidepressants, antihistamines, antipsychotics, antiparkinsonism, antispasmodics, amantadine, mushroom poisonings. I will probably like to highlight one of the case where Dr. Vijay was talking to me that one of the drug during her stay in the hospital was one of them. I think was some Vijay was here. What was the drug? A cholinergic crisis. So these are the not uncommon to have some antihistaminics there or some cholinergic drugs there, which has not been noticed during your flow, and the patients consistent to have some of these kind of symptoms, and then finally you land up anticholinergically. So again, the treatment remains to be the same, like cooling and probably using some sedatives, discontinuing those things, and you can use a physostigmine as a drug in them. We'll not go into the details. This is one ECG where any clues? Positive R-way deflection in this overdose. I will repeatedly talking about the same drug 2-3 times. So this is a TCA overdose, which is again, nowadays we are seeing less and less, but this was one of the commonest overdose which when the antidepressant drugs TCA was in a rampant use, and you can see the R-axis deviation with R-way being positive deflection. Bicarbonate therapy and probably physostigmine can be used with benzodiazepam in them. Another 15-year-old girl from a rural area brought to the emergency department by with the family on a bus, and she has a loss of consciousness, drooling, tearing, streaming, and tachycardic, respiratory rate being 16, BP being borderline hypothermic. So this is again a cholinergic toxidrome with all the sludge and whatever nicotinic. You have a muscle cramps, tachycardia, weakness, twitching, fasciculations. So there were different mnemonics like sludge, like dumbbells and all. And this we commonly see with all the common organophosphates, insecticides and carbamates which generally have. And one of the cholinergic drug which they used in prostate treatment, so bladder contractility wise. So the same way, some of those drugs which can mimic like a cholinergic, that's what is the phenomenon when it happened to one of our patients here. So the treatment wise, we will not go into the details. The standard decontamination, airway management, and antidote of atropine and pralidostigmine has gone into a controversies, but some of us still believe in pyridostigmine. The case 4, a 26-year-old male found on the street by the police, no family present. The eyes are bloodshot, agitated, sweaty, uncooperative, tachycardic, hypertensive, respiratory rate is 20, and temperature is normal. So this is again a sympathomimetic toxidrome. The maths is the mnemonics, mydriasis, agitated, with tachycardic, hypertensive, and seizures and sweating are the common syndromes. And more common sympathomimetics which actually presented to us is cocaine overdose, amphetamines, and some of those derivatives which we see. So one of the things, like if you see the common things which we have seen is agitated, aggressive, dilated pupils with hypertensive response. You have seen both in anticholinergics and sympathomimetics. So both has the same kind of phenomenon. But there are few things which can differentiate between anticholinergics and sympathomimetics. That is, skin will be generally dry and red in anticholinergic, where it will be moist, and where there will be perspiring in sympathomimetic. GI, there will be hypoacute in acute anticholinergic, where it will be hyperacute and bowel sounds will be more pronounced. Urinary retention is generally seen in anticholinergic, where you will not see a bladder full in kind of a sympathomimetic drugs. So these are the common overlaps which you need to know. Again, the treatment I will not go, they have been standard and keep on monitoring them. The last case, a 42-year-old female found at home by a daughter unresponsive in the bed. Heart rate looks normal, respiratory looks very low, GCS is low as expected, hypothermic, blood pressure is low, pupils pinpoint. Any clue? So these are the all 5 syndromes which I will talk about, and all of you should be knowing this. And there are mnemonic CPR, 3H, coma, pinpoint people, respiratory depression, hypotension, hypothermia, hyperreflexia. So again, here we use antidote naloxone, and most of the times it's a long acting, so we do get the results, and sometimes we may need to repeat our infusion. And again, naloxone we use as a diagnostic drug also. It's not just a drug to actually reverse, but diagnostically. So whenever we receive a patient with an opioid intoxication, we try to give an naloxone and try to find out whether there is any reversibility with the naloxone or not. So these are the 5 toxidromes which I wanted to talk to all of you. If you see anticholinergics, cholinergics, opioids, sympathomimetic and sedatives. So this is the broad classification in an emergency room where you will look at the blood pressure, heart rate, respiratory rate, temperature, pupils, bowel sound and diaphoresis, and you will see whether they fit into any of these toxidromes. These are a broader guidelines to say which category they are. If I have a patient who is deeply sedated with drop in heart rate, drop in blood pressure, drop in respiratory rate, hypothermic, pupils are normal to low, low bowel sounds, no diaphoresis, I will talk about a hypnotic or sedative. But when my heart rate, blood pressure is high, respiratory rate is high, temperature is high, pupils are fully dilated, bowel sounds are active, I am moist, probably I will talk about a sympathomimetic drugs. The similar way, the heart rate and blood pressure may be little high, pupils will be dilated, and bowel sounds and diaphoresis will not be there. We talk about an anticholinergic. Cholinergic, we all know about them, the pinpoint pupils like sludge or dumbbell, whatever synonyms we use. So this is again a broad classification how we approach a patient who comes with a tachycardia and hypertension, and you have an agitated behavior, patient is delirious, patient had a bilateral dilated pupils mydriatic, there is a rise in temperature. You then see whether the patient is dry in skin or the patient is moist. The bowel sounds are present or absent. Urinary bladder retention is there or not there. Then you classify them possibly anticholinergic or a sympathomimetic. Then if a patient comes to you with a suspected poisoning is in bradycardia and hypertension, you check glucose. If they are hypoglycemic, you talk about a possibility of a beta blockers in them. If they have a bradycardia, hypertension, you are suspecting some antihypertensive overdose. If the patients are hyperglycemic, you consider possibility of a calcium channel blockers in them. If a patients are bradycardic, hypertensive, drowsy with respiratory depression, with pinpoint pupils, talk about or think about opioids possibility. If the patient is drowsy with respiratory depression with normal pupils, as I told, talk about a sedative hypnotics. If a patient with bradycardia and hypertension has a sludge or a dumbbell, considered a cholinergic possibilities in them. So with this, I wanted to talk about 2 more things which are very, very important and clinical pulse in critical care. I received a patient from this part of Kukatpalli. One of our consultants received this patient, and the patient comes in an altered sensorium with severe breathlessness. And the oxygen levels, the previous hospital ER says 70 or 65. Lungs looks absolutely normal, and a ABG taken in that hospital says 450 PaO2. And the saturation in that ABG suggests it is 99 in ABG. Whereas pulse oximeter saturation suggests 70, and the patient is breathless, and patient's lungs are normal on auscultation, on X-ray, on CT. And there is no thromboembolism, RA-RV are normal. So methemoglobin, absolutely. So there is a saturation gap. The saturation in ABG is 99%. The saturation in the pulse oximeter is 70. So there is a saturation gap because of abnormal hemoglobins. The co-oximetry, we have a co-oximetry in most of our ABGs in tertiary care centers, which gives you the percentage of methemoglobin, which is extremely low in a normal individuals, but it was 28 in this patient which we are talking about, and we treated with methemoglobinemia. And we also see patients, otherwise a software engineer in a Google, a high profile girl, scheduled to have a marriage in the next week, came to us in a severely acidotic, hypertensive, and the acidosis to extent of 6.9 pH, needing a immediate bicarbonate push and switching to a dialysis to just save that patient not going to impending cardiac arrest. Later on, the metabolic acidosis was very high anion gap metabolic acidosis. Lactates were not very profound, so we had no clue why this patient had such a high anion gap metabolic acidosis, otherwise normal. And when we went back and saw for both osmolarity calculated by sodium, urea and glucose, which we do, and also the serum osmolarity which has been sent to the lab, there is a huge osmolar gap. So is there any clue? The osmolarity which is calculated in this case and the osmolarity which has been sent, there was a reason why this osmolarity was sent. The osmolar gap is to find out whether there is any high osmolar gap, high anion gap metabolic acidosis, which indicates towards a ethylene glycol poisoning or a refrigerator poisonings, and there was no clue from anyone that this girl has any intoxication in any form. Then how do we, they are all tech girls, so they could actually open at the end of the third day the desktop with a password, and they found this girl's Google search history searches about this all the point of poisonings, and then she goes which can actually help her and which is easily available. She goes to the ethylene glycol and cooling refrigerators, and then we found a slip that one of the stores where we went, this automobile stores where she bought this ethylene glycol as a cooling agent, saying I need a coolant. So this has been used. So these are again two pearls. If I have a patient where there is a saturation gap, I will inquire about is there a methemoglobinemia. This person who came to us with methemoglobinemia was a painter and aniline dye was used in them. The saturation gap, the osmolar gap patient who has a high anion gap, metabolic acidosis lady, finally needing a dialysis. Finally, we talk about different fomepizole replacement or different things. We tried again ethanol, and ethanol was not available at that time as a medical therapy. And out of the regular context, without a documentation, we used ethanol in this lady for 5 days as a therapy, dripping a ethylene bottle with some of our colleagues' help. And finally, this girl walked out of the hospital after these therapies of 5-6 days. So these were the overall view of Toxidromes, 5 Toxidromes, cocktails, and all this. With this, I just waiting for a gathering which will make this so, the whole efforts of the clinical pearl to roll on. And our idea was to bring this clinical medicine into action and giving the clues to all our junior colleagues or our friends.